Warm good evening to one and all. Um, Hope all of you are enjoying the sessions and all of you are attending after your long days too. Um, our topic today is also equally important to know what are the emergencies that can be there and how we deal with them. To take us through that, we have Dr. Jewell Joseph, a radiation oncologist who's an assistant professor in Christian Medical College Fellow. And he is faculty in few of the courses. And his main areas of interest being community palliative care and home-based palliative care, which are essential so that palliative care services reach the needy who are in real need of it. So with that, I pass over on to Dr. Jewell Joseph to take us through this.
Thank you so much, ma'am. Good evening, all. I hope I am audible. So happy to be here with all of you. So I'll share my screen.
Yes, go ahead. Your voice is clear and you can start screen sharing.
So today's discussion is based on the emergencies in palliative care. So I hope you all are having a good series of sessions. So usually when I mention regarding emergencies in palliative care to my friends, so the usual comment is, do you really have emergencies in palliative care? So the general concept of palliative care is where we do things very calmly and slowly. So we don't do any like emergency interventions or sudden invasive managements. So in reality, in palliative care, we face all the emergencies that any other medical specialty routinely faces. But the approach that we take to emergencies is something slightly different from the approach that we usually take in other medical specialties. So I'll just go to the first slide. So what an emergency basically means is any medical condition that is a threat or that poses a threat to the life or quality of life of the patient without an immediate intervention. So especially in palliative care, we take the second point also very seriously. So even if it doesn't necessarily pose a threat to the life of the patient, if it seriously affects the quality of life, so should take it as an emergency. So I remember Dr. Robert Wycross, who is one of the pioneers in palliative care, in one of his lectures saying that any patient who has not passed stools for the past 5 days is an emergency. So I mean, you get the sense, right? So any condition which actually poses a threat to the quality of life of the patient also is considered as an emergency in palliative care. So while dealing with an emergency, the usual things to consider or the questions to ask are, so the first question is to, or the first aim of any medical professional is to find out the risk of developing an emergency so that we actually anticipate the emergency to occur and we take the precautionary measures so that we finally don't end up with a sudden crisis or an emergency. For example, if there is a patient having a spinal cord metastasis, sorry, a vertebral metastasis having a back pain, or a metastasis or a metastatic lesion in a long weight-bearing bone who is supposed to, I mean, who is very likely to get a pathological fracture. In such cases, we should identify such patients early and take preventive measures as far as possible so that we can actually prevent that emergency from happening. So that is the first thing to consider when any patient comes to you. Second thing is, if unfortunately an emergency occurs, the question to ask is whether it is reversible or not. So if that is not reversible, so there is no point, especially in a patient towards his end of life or having an advanced disease. So there is no point in doing some futile investigations, some aggressive investigations if that condition as such is not reversible. So if it is reversible, by all means, we can do whatever can be done to reverse it. So the next question, if it is reversible, the next question to ask is there a meaningful benefit? For example, the example that I usually tell is if there is a bedridden patient who is nearing his end of life, so you feel that the patient actually develops a weakness in his left leg on one fine morning. So you find a neurological deficit. So there is no point in going on investigating and correcting that, because anyway the patient is completely bedridden, nearing the end of life. So such conditions we should take a wise call. So if at all a condition is reversible, the question to ask is whether there is a meaningful benefit. And finally, and not very importantly, so what does the patient and family want? So especially as palliative care physicians, we take pride in actually advocating the patients and families' wishes. So that thing that that the wishes of the patient and family should also be taken into account whenever we take a decision. These are the things to consider when we are dealing with an emergency. So as a as an introduction, I'll just tell you that uh, as I mentioned earlier, we come across all the usual emergencies that we come across in all the other medical specialties. So it is impossible to go through the detailed management of each and every emergency in this particular presentation. It is way beyond the scope of this presentation. So what I am trying to do essentially here is to give you a bird's eye view of major emergencies that we come across in the day-to-day practice. So for the sake of listing and for the sake of explanation, I have divided it into the emergencies that we encounter in various systems. So this is a list. So in the neurological system, the usual things that we come across are spinal cord compression, increased intracranial tension and delirium. Respiratory system mostly will be airway obstruction. Vascular system, superior vena cava obstruction and hemorrhage. Metabolic things would be hypercalcemia and hyponatremia most commonly. Skeletal system would be pathological fractures. And last but not the least, pain crisis and opioid overdose is also a possible emergency that we can come across. So again, going through each of this uh, not possible within the time limit that we have. So we'll actually deal with one or two of the uh, emergencies from each system and just give a brief overview of how we go about managing those emergencies. To start with, we start with the neurological symptoms. One of the most common emergencies that we deal with in palliative care is malignant spinal cord compression. It occurs, please interrupt me if you have any questions or if I am going too fast. So malignant spinal cord compression occurs in about 3 to 5% of all cancers. So the most common solid tumors that causes malignant spinal cord compression would be prostate, lung, and breast. So these are the most common causes of bone metastasis as well. So naturally, spinal cord compression secondary to vertebral metastasis is also most common with these tumors. Hematological malignancies, the most common would be malignant myeloma, which is again a disorder of the plasma cells, which is characterized by multiple bone lesions, which are susceptible to breakage. So spinal cord compression secondary to vertebral fracture is also very common in multiple myeloma. The most common site is thoracic spine. The most common site is thoracic spine because two of the most common solid malignancies which can cause bone metastasis are found in the thorax, lung, and breast. And again, breast has direct connection, venous connection to the vertebral plexus through its venous supply. So thoracic spine is the most common site of spinal cord compression, secondary to vertebral metastasis. So malignant spinal cord compression can cause pain, mechanical instability of spine, and neurological deficits. So coming to the pathophysiology, so basically what happens is if there is a tumor which is nearing the spinal cord or in the bone, which actually goes into the dural space, there will be compression resulting in venous stasis. So again, there will be interleukins and prostaglandins and other inflammatory cytokines being secreted secondary to this venous stasis. There will be vasogenic edema because of venous stasis and these inflammatory cytokines. There will be vasogenic edema. Vasogenic edema, if uncontrolled, will eventually lead to ischemia, and ischemia will finally lead to infarction. So you can see a tumor coming inside the dural space, which again goes around the spinal cord and finally resulting in spinal cord compression, ischemia, and infarction. So this is the natural history or pathophysiology of spinal cord compression. So coming to the signs and symptoms, the most common sign of or symptom of spinal cord compression would be back pain. It occurs in 95% of the patients. In 40% of the patients, there may be a radicular pain secondary to nerve root compression. There can be neurological symptoms like sensory deficits and motor deficits. There also can be autonomic symptoms like bowel and bladder dysfunction. So spinal tenderness is another clinical sign that we can elicit. If there is a vertebral fracture, the corresponding segment would be tender to palpation. So that is something that we can elicit. Again, there is neurological and autonomic signs that we can uh, find out during our examination. The most common thing about back pain is it is it is the most common symptom. And again, back pain in spinal cord compression or generally pain in spinal cord compression occurs days or even weeks before the onset of neurological symptoms. So we'll see in the coming slides that once a neurological symptom occur or once a neurological deficit occur, it is usually very difficult to reverse it completely. So it is very important to pick up early, pick up these patients early so that we can actually treat them well. So since back pain or pain occurs much earlier when compared to the neurological symptoms, any back pain in a patient with a malignancy should be considered as malignant spinal cord compression unless proved otherwise. So that is one important thing to keep in mind when we are dealing with these patients. So coming to the diagnosis, the gold standard would be MRI, obviously. So X-ray can also have its value if there is a fracture. So with soft tissues and nerve compression, disc, all those things will not be seen in the X-ray, obviously. But if you're suspecting a vertebral fracture and since it is quick to get, so X-ray has its own value, but the gold standard would be always MRI. The important thing to keep in mind is that whenever we are doing an X-ray or an MRI for evaluation of a malignant spinal cord compression or a vertebral fracture, it is always advisable to screen the entire spine because it is said that whenever there is a vertebral fracture or a spinal cord compression at one side, there is a 30% chance that another segment of the spinal cord or another vertebra has another fracture or a significant metastatic lesion. So it is always advisable to screen the entire spine rather than focusing on the area of symptom alone. So coming to the treatment. So the initial treatment would be immobilization or bed rest. So if you are suspecting a fracture or something. So pain can be controlled by analgesics, opioids and adjuvants. So whether to give NSAIDs is one question. Uh, See, the thing is NSAIDs are usually very useful in pain control. But the reason that I have put it in red and the question mark, we'll come to in the next slide. So just keep that in mind. So the ideal thing, so generally what we give for pain in spinal cord compression is opioids and adjuvants for neuropathic pain. So if there are bowel and bladder disturbances, we can give laxatives, do digital rectal evacuation and catheterization for urination. All those things symptomatic should be done as a part of treatment. So treatment of the cause is the next thing. So these are the previous slide was symptomatic measures and next would be the treatment of the cause. So the first thing that we can usually give for spinal cord compression is steroids. So two things I'll mention about steroids because I'll be continuing to mention steroids in the coming slides. First of all, whenever I mention steroid in this particular presentation, I am referring to dexamethasone, which is the usual steroid that we use in palliative care. The second thing is steroids have a value whenever there is a peri-tumor edema and associated infection, so associated inflammation. So basically, whenever there is a compression secondary to a tumor, whether it is in the central nervous system or in the peripheral nervous system or in the bowel or wherever it is, there is usually some associated peri-tumor edema and surrounding inflammation that will actually add to the mechanical component of the obstruction. So steroids will reduce the peri-tumor edema and also the surrounding inflammation, which will actually can reduce the magnitude of the obstruction. So whenever there is an obstruction secondary to a tumor, steroids usually has a value. So that is why we are giving steroids here in malignant spinal cord compression. Often in patients with malignant spinal cord compression, steroids can produce a drastic effect quickly. But the problem with steroids is that the effect of steroids tend to wean away as time passes. So what we usually do is give steroids for a short period of time, then taper it off and do the other measures which are uh, there for the treatment of the cause and not to continue it for a long time because its effects actually diminishes over time. So the reason why I put NSAIDs in red letters and a question mark previously is that you very well know that whenever we give steroids with NSAIDs, there is an increased chance of ulceration in the stomach. I mean, the increased chance of gastric problems, increased chance of gastric ulcer. So that is why, so since we usually give steroids for malignant spinal cord compression, NSAIDs we don't usually give along with it. So the usual drug of choice for analgesia will be opioids, either a weak opioid or a strong opioid according to the pain severity. And we usually tend to avoid NSAIDs along with steroids. Second thing would be surgery. The surgery has a definite role whenever there is an instability of the spine. So if there is a vertebral fracture, when there is an unstable segment which is causing compression, fixing the spine and stabilizing the spine has a role in malignant spinal cord compression. Radiotherapy has a role. Radiotherapy will help in reducing the pain and also in tumor control by shrinkage of the tumor. Chemotherapy especially is useful in hematological malignancies and malignancies which respond to chemotherapy very well. So for example, lymphoma and multiple myeloma, etc., usually responds well to chemotherapy. So in such cases, chemotherapy has a role also. So the treatment of the cause should be according to the primary tumor and the nature of the disease. So a little bit in detail about steroids. As I mentioned, I am by steroids, I am telling dexamethasone. So it has anti-inflammatory and anti-tumor effects. The usual dose of steroids that we give for these kind of patients would be 16 to 24 milligram per day. It can be tapered off once definitive treatment is initiated. So as I mentioned earlier, gastroprotection if is usually advised along with steroids, and concurrent use of NSAIDs are ideally avoided in case of steroid usage. So other treatment options, as I mentioned, radiotherapy, surgery, and chemotherapy according to the tumor biology and the stage of the disease and many such factors, patient factors, etc. So coming to the prognosis, the most important prognostic factor in malignant spinal cord compression would be pre-treatment ambulatory status. So, and the second prognostic factor, most important, would be time of initiation of treatment from the onset of motor deficit. So the better the pre-treatment ambulatory status is, the better the prognosis is. The more mobile the patient is prior to the onset of treatment, the more chances that we have in maintaining those status. Again, after the onset of neurological symptoms, the first 48 hours is usually crucial. So if it usually goes beyond 48 hours after the onset of neurological symptoms, it is said that it is very difficult to attain the pre-deceased neurological. So it is very difficult to attain a complete normal ambulatory status of the patient, which again takes us back to our initial point that the pain is a very important red flag in a patient with a malignancy. Back pain is a very important red flag in a patient with malignancy. So since pain occurs, I'm repeating again, since pain occurs days and weeks before the onset of neurological symptoms, any back pain in a patient with a malignancy should be considered as a malignant spinal cord compression unless proven otherwise. So that we are coming to the brain. So the most common thing that we come across is increased intracranial tension. So it can be because of either a metastasis to brain or to the meninges or due to a primary brain tumor. So the most common tumors that metastasize to the brain are lung, breast, and melanoma. So symptoms the usual symptoms of increased intracranial tension would be headache, vomiting, seizures, altered sensorium, etc. So the treatment again, as I mentioned earlier, steroids because of the anti-tumor properties. More than that, decreasing of the peritumor edema and also the associated inflammation. Osmotic diuretics is something that we usually give, like mannitol, but there are the issue with osmotic diuretics is their effect actually plateaus off very quickly. So even if we are giving osmotic diuretics like mannitol, so we usually give it for a very short duration, like 3 to 5 days, and then stop it. So surgery, another treatment option whenever there is a solitary brain metastasis or which can be well operated. So surgery is an important tool. So radiotherapy is another option, which can be a stereotactic radiosurgery where a very concentrated amount of radiation is given to a small lesion in the brain. So stereotactic radiosurgery can be useful in solitary metastasis or a very small number of brain metastasis. So if there are multiple metastases in the entire brain, we have to irradiate the whole brain, which is known as the whole brain radiotherapy, which will have a lower dose and a shorter duration of treatment. I mean, in the sense, stereotactic radiosurgery will be like a higher dose, and whole brain RT will have a lower dose. So chemotherapy and targeted therapy are other options, especially in patients with carcinoma lung and all. So there are newer targeted therapy agents which actually crosses the blood-brain barrier. So the issue with chemotherapeutic drugs are most of the chemotherapeutic drugs do not cross the blood-brain barrier. So even if we have a good symptom, good disease control in the other parts of the body. So there is a risk of brain metastasis developing because these drugs usually do not cross the blood-brain barrier. But with the advent of new targeted therapy agents, which can actually cross the blood-brain barrier, usually patients with brain metastasis also get a good response with targeted therapy agents. So analgesics, again, the ideal analgesics to use here will be paracetamol or NSAIDs if you're not giving concurrent steroids. The problem with opioids is technically all opioids can actually increase the seizure threshold, decrease the seizure threshold and increase the risk of seizures. So in such cases, opioids are usually avoided if not necessary. And tramadol is especially notorious in this regard. So when opioid is necessary, we usually use morphine rather than tramadol. Again, with adjuvants, we usually use antidepressant agents as adjuvants for neuropathic pain. So technically, antidepressants also lower the seizure threshold, which actually increases the risk of seizures. So such agents should be avoided in such cases. We can use anti-epileptic drugs as adjuvants in these cases. So paracetamol, if the pain is usually controlled with a step 1 analgesic, paracetamol will be better. So we are moving into the respiratory system. So the most common thing that we usually come across in respiratory system would be airway obstruction. So airway obstruction can be either intrinsic or extrinsic. So if the tumor can be inside the airway or outside the airway, it can cause compression. It can be acute or subacute. So subacute airway obstruction usually develops over a time. I mean, not like a sudden thing. It usually develops over time. So the most common symptoms of presentation would be shortness of breath and stridor, typically is an inspiratory finding. So management would be oxygen, steroids, because of the same reasons that we mentioned earlier, opioids and benzodiazepines if the patient is very breathless. Opioids actually reduces the work of breathing. So you must have actually come across the role of opioids in breathlessness. I assume that you must have come across the role of opioids in breathlessness in the other classes. So basically what opioids like morphine does is it actually reduces the work of breathing. And in a carefully titrated dose, it usually never causes respiratory depression. We can add a benzodiazepine if the patient is anxious. So it can act as an anxiolytic. So radiotherapy, if there is a tumor compressing the airway or a tumor blocking the airway, radiotherapy can be beneficial, which actually will shrink the tumor and will relieve the obstruction. Tracheostomy is another option if that is an upper airway obstruction. Obviously not for an not for a lower airway obstruction, but the benefits and risks of tracheostomy should be definitely discussed with the patient and family. Also, we should take into account the disease status, the response to primary therapy and all those things. So tracheostomy is an option when there is an upper airway obstruction, which should be taken on a patient-to-patient basis. So the next thing would be acute airway obstruction, which actually has a severe progressing dyspnea and usually associated with a hemodynamic collapse. So unlike the subacute airway obstruction, in an acute airway obstruction with a hemodynamic collapse, there is very little that we can do actually to change the disease trajectory. So what we can usually do is sedate the patient so that he'll be not distressed, and also family education and support. So this is a very unfortunate situation. We may find ourselves helpless, but we should actually focus on the patient comfort and family education and support in this patient. That is all that we can do. So we are coming into the vascular group of emergencies. So this is one common thing that we come across. I think that the presentation after case presentation after the discussion also have an SVC obstruction. So SVC obstruction, this is something that we must have learned from our MBBS days, the typical signs of SVC obstruction: pulseless JVP, dilated veins over the chest. There may be corneal, facial edema, conjunctival edema, cerebral edema in severe case. So this is a typical picture of an SVC obstruction. So superior vena cava obstruction can be because of a bronchogenic carcinoma, lymphoma, mediastinal germ cell tumor, etc. So the treatment would be, the first thing in the recent guidelines, the first ideal treatment option for superior vena cava obstruction would be endovascular stenting. So previously we used to consider radiotherapy as the gold standard of SVC obstruction, but recent studies have shown that stenting is a safer, like more effective way of treating SVC obstruction. We'll come to that in detail in our after discussion. I mean, the case presentation if we require to, but just keep in mind that the current standard of treatment for SVC obstruction is stenting, endovascular stenting. So it in a recent systematic review which was published in 2022 showed that endovascular stenting in SVC obstruction has a technical success of 98% and a clinical success rate of 93%, and only 6% of the patient required a repeat procedure or a further management of further complication. So it is usually a very effective and a very safe procedure. So whenever possible, if that option is available, stenting has to be done, and the effect of stenting is usually immediate. It happens in zero. The effect can be seen within 0 to 72 hours. So steroids, again, I'm not going into steroids and again and again. The basic idea: peritumor edema and surrounding inflammation. Radiotherapy was previously considered as the gold standard of treatment for SVC obstruction. The issues with radiotherapy is the effectiveness of radiotherapy is only 80% when compared to the 93% of percent effectiveness in stenting. So radiotherapy has an 80% effectiveness, and also the effect of radiotherapy usually takes a little bit more time, up to 2 weeks to completely. It may usually take up to 2 weeks to completely see the effect of radiotherapy. Chemotherapy, especially if that is a tumor which has a good response to chemotherapy, like small cell lung cancer or a lymphoma or a GCT for that matter, chemotherapy can be an important treatment option. Diuretics and bronchodilators we usually used to give previously. I mean, diuretics, again, the idea of diuretics is to take water, more water from the body and thereby reducing the venous return and all those things. But again, the role of diuretics is usually questionable. The only thing that is clinically proven to be beneficial would be steroids. Bronchodilators again can be given, but the effect is again questionable. There are some non-pharmacological measures that we can usually do for these patients. We can put them in proper position, and we can actually tell our healthcare providers not to give any IV fluids through the upper limbs, which will actually again aggravate the obstruction and the edema of the patient. So these are the details regarding SVC obstruction. So the next thing would be hemorrhage in the vascular thing. So hemorrhage can be because of the tumor infiltration to blood vessels or marrow infiltration and thrombocytopenia. It can actually be because of a tumor primarily or as a treatment related complication, especially of chemotherapy. So tumor infiltration to blood vessels can cause bleeding. If a tumor infiltrates the bone marrow, which can actually cause thrombocytopenia and cause bleeding. And similarly with chemotherapy, with very high dose cytotoxic chemotherapies can cause bone marrow depression, thrombocytopenia, and thereby lead to bleeding. Another possible pathological cause of hemorrhage in this patient would be if a tumor metastasis to liver, and if there is a gross derangement of liver function, there can be deficiencies in bleeding. There can be changes in bleeding time and clotting time, and which can eventually lead to bleeding also. It can be minor or major. So management of minor bleeds would be like general measures like transfusions, vitamin K and FFP if that is required. So bleeding control can be achieved by some medications like tranexamic acid, and hemostatic RT is also a very important tool in controlling the bleeding. So we usually give a smaller dose when compared to a curative RT, but RT can be an important tool in achieving hemostasis, especially when there is a tumor that is amenable to RT, which can like head and neck tumor bleed or a cervical bleed, all those things. And there are other site-specific management also for minor bleeds. For example, organ plasma coagulation. This is usually one thing that we come across in radiation proctitis. So radiation proctitis, even after the curative treatment, can cause continuous bleeding in such patients. So in such cases, we can do an endoscopy and organ plasma coagulation, which can arrest the bleeding, and also steroid and sucralfate enemas in this case patients are also beneficial. So major bleeds, as I mentioned previously, with subacute airway obstruction and acute airway obstruction, if that is a huge bleed with blood gushing out of the tumor, there is not much that we can do in order to arrest the bleeding per se. So what we can do again is focus on sedating the patient and comforting the patient as much as possible, and family support. We can give opioids. We can try to sedate the patient with some benzodiazepines. So again, with major bleeds, the sight of blood is something that is very traumatic, especially to the caregivers and sometimes to the patients. So in such cases, it is advisable to use dark towels so that the sight of that gory sight of blood would be masked. And again, family support, hand holding, and all those things that we can do to support the family. And to alter the disease process per se, and I'm afraid that in major bleeds, that is usually something that we cannot do. So we'll come into the skeletal system. This is regarding pathological fractures. Again, as I mentioned earlier with spinal cord compression, so these are the tumors that usually presents most commonly with the bone fracture, like lung, breast, and prostate. These are the most common causes of bone metastasis in solid tumors. And myeloma is again primarily presents as multiple bone lesions. So again, pathological fractures, the gold standard treatment would be surgical fixation. So analgesia can be obtained by analgesics according to the WHO step ladder, according to the severity of the pain. Adjuvants can be given for any associated neuropathic pain. Usually, bone meds are usually associated with the neuropathic component of pain also. So adjuvants can be beneficial. Bisphosphonates and denosumab. So these agents are beneficial whenever there is a cancer tumor related, the bone lesion related, osteolysis related hypercalcemia. So bisphosphonates and denosumab can bring down the calcium in the blood. They can also strengthen the bone in long time and preventing skeletal related events in the future. So basically the idea would be to prevent fractures in the future. So bisphosphonates and denosumab can be beneficial in that regard. Also, they will reduce the hypercalcemia related to osteolysis. So in pathological fractures, as we mentioned in the first slide, risk identification is a very important thing. So rather than a patient getting pathological fractures and being miserable, it is always good if we can identify the risk earlier. So actually, there is a criteria called a Mirror scoring system that help us predict the risk of pathological fractures. So I'm not going into the scoring in details, but so basically that scoring takes into account the site of the lesion, the amount of pain, X-ray appearance, and size of the lesion. So obviously in weight-bearing bones, the risk of fracture is more. If there is more pain, like a functional pain, whenever the patient is moving around, if the pain associated with any movement, there is an increased chance of fracture. The lytic lesions are more prone to fracture when compared to blastic lesions. And if more of cortex is involved, there is an increased chance of pathological fracture. So this is a scoring system that help us predict the risk of pathological fractures in such patients. So we'll come into the gastrointestinal system. This is a malignant bowel obstruction. Malignant bowel obstruction occurs in 3 to 5% of patients with malignancies. It can actually occur anywhere from esophagus to rectum, but the most common site is small bowel. So the most common cause of malignant bowel obstruction is interestingly not a primary bowel cancer. Ovarian cancer has the highest incidence of malignant bowel obstruction, with incidences ranging from 5.5 to 42%. So that is because peritoneal spread in ovarian cancer is very common. That can be the reason for increased bowel obstructions in ovarian cancers. It is closely followed by colon cancer, with an incidence of 4.4 to 24%, and other bowel cancers and various other malignancies. So usually malignant bowel obstruction is a poor prognostic factor, especially in a patient with an advanced disease. Once that occurs, the median survival is usually 1 to 3 months. So again, based on the extent, it can be either a partial obstruction or a complete obstruction, which is very clear from this picture. So, and based on the level, it can be classified as a single obstruction and multiple site obstruction, single site and multiple sites. So based on the levels of obstruction. So coming to the pathophysiology of bowel obstruction. So whenever there is an obstruction, so there will be a proximal dilatation or proximal distension of the bowel, because that bowel contents will be stagnating there and there will be some proximal distension. So the initial response of the body would be to increase the peristalsis and increase the secretion to push that content through the obstruction. This is basically the same like the same thing that we'll do whenever there is an obstruction of our kitchen sink, right? So whenever there is an obstruction of our kitchen sink, we'll basically what we'll do is we'll take a stick or something and try to push it through, and we'll flush it with water. So the body does the same thing. So initially, in the first stages of obstruction, body will try to counteract with increased peristalsis and increased secretions. So whenever there is increased secretion, there will be bacterial overgrowth and there is increased gas formation. So if the that obstruction is not relieved, so what happens is increased secretions and gas will again increase the amount of distension, and this cycle will continue for some time. So at this stage of the disease, there will be pain, bloating, nausea, and vomiting. So this is the first step. So as time progresses, if the obstruction is not relieved, the distension actually goes on increasing. When the distension reaches above a particular limit, there will be some associated inflammation also. This inflammation will eventually lead to bowel edema. So bowel edema will again increase the obstruction because there will be more edema, more obstruction. And this again continues as a vicious cycle. So finally, if the obstruction is not relieved, the bowel will get edematous, it will get distended, and finally there will be bowel ischemia. So ischemia, once the bowel is ischemic, and if that goes on for some time, there can be perforation and peritonitis, eventually leading to sepsis and multi-organ dysfunction syndrome. So these are the this is the natural history of the bowel obstruction. So at the I have mentioned in the previous slides that at the early stages of obstruction, there will be increased colicky pain, increased peristalsis. There will be also like clinical signs like visible peristalsis and all those things that we can elicit. But in the final stages of obstruction, the colicky pain actually disappears because there is no peristalsis because the bowel is dead, and it is more like a distension. Along with the most common site would be a dull aching pain and would be distension. There will be no clinical signs like visible peristalsis, and it will be more like a distension in the final stage. This is the natural history of bowel obstruction. So again, the symptoms of bowel obstruction that we can find out early will depend on the level of obstruction. So for say that if there is a proximal bowel obstruction in the gastric outlet, so whenever there is an obstruction here, it will be easier for the body to take it out as vomiting rather than trying to push it around, push through this obstruction all the way down here. So for proximal bowel obstruction, there will be early vomiting. But in contrast, if there is a distal bowel obstruction somewhere in the large intestine, it is very difficult to vomit it out because it has to travel all this way through the stomach and then come out. So the initial sign would be constipation rather than vomiting. Vomiting only occurs in the very end stages of the obstruction. So this is a chart, this is a table comparing the symptoms in proximal obstruction and distal bowel obstruction. A proximal obstruction, the pain would be upper or central abdominal colic. So basically, according to the site of the obstruction, distal obstruction would be the site of pain would be central to lower abdominal colic. Vomiting would be early and severe in proximal bowel obstruction, that like we saw in the previous slide. In distal bowel obstruction, vomiting is usually late and less. Distension is usually absent in proximal bowel obstruction. Why? Because whatever obstruction is that is getting vomited out. So abdominal distension is not a prominent feature of proximal bowel obstruction. But in distal bowel obstruction, abdominal distension is present because the bowel contents are getting stagnated over time. Constipation is usually less in proximal GI and usually the most common presenting symptom of distal bowel obstruction. So these are the symptoms which are the contrasting symptoms between proximal and distal bowel obstruction. So investigations, the usual thing that we can do first to confirm the bowel obstruction is X-ray. So we'll come to the classical findings later. But X-ray usually can confirm bowel obstruction. There can be dilated bowel loops, air fluid levels, etc. But if you actually find out the cause of obstruction with more sensitivity and severity, CT scan would be the investigation of choice. It actually finds out the cause of bowel obstruction by 93% sensitivity and 100% specificity. But whether to go for a CT in such cases would be a matter of clinical discretion according to the condition of the patient, stage of the disease, etc. So another useful investigation that we can do is electrolytes. So whenever a patient comes with obstruction, there are two reasons for that. So if there is an upper GI obstruction and the patient is vomiting continuously, there can be an electrolyte loss from the bowel, which can be corrected if we check the electrolytes. Second thing is dyselectrolemia, especially hypokalemia, can itself be a cause of bowel obstruction where there is no mechanical obstruction, but there can be a paralytic ileus and the symptoms can be similar. So electrolyte is one investigation that is worth doing in such patients. So this is a typical example of air fluid levels, typical example of an X-ray in bowel obstruction. So the thing with small bowel obstruction and large bowel obstruction is there are various criteria for this. So usually it is said that more than 5 air fluid levels with the length more than 2.5 centimeters suggestive of bowel obstruction. Even if there is no visible air fluid levels, according to the dilation of the bowel, we can actually have an idea about the obstruction. It is said that any proximal, like small bowel dilation more than 3 centimeter, along with the decreased distension of the large bowel is indicative of a small bowel obstruction. So small bowel dilation more than 3 centimeter with less than 6 centimeter dilation in the cecum and less than 9 centimeter dilation in the colon is usually suggestive of a small bowel obstruction. It just basically means that small bowel is getting dilated, not enough air is going into the large intestine. So similarly, if there is more than 6 centimeter dilation in the cecum and 9 centimeter dilation in the colon, it is usually suggestive of a large bowel obstruction. These are various radiological things that we can look into whenever we are trying to diagnose a bowel obstruction. So coming to the non-pharmacological measures. So basically, during our PG times, whenever a patient is having a bowel obstruction, whether they have vomiting or something, the 3 things that we usually do is keep the patient in NPO, put in an NG tube, and IV fluid. So these are the 3 things that we usually do. So it is a good thing to rest the bowel, because it is said that 1/3 of the obstructions actually gets relieved by themselves. So if you can actually rest the bowel for 2 or 3 days, it can actually, some cases can actually reverse. But the thing is, if you know that there is a proper obstruction which is unlikely to resolve, you have been expecting this for quite some time, and finally the patient goes into an obstruction. So it is not something that we can, if you are expecting it be something not possibly reversible. So there is no need to completely put the patient in NPO. We can actually take some sips of fluids or suck on an ice cube, so just to alleviate that thirst. And IV hydration and subcutaneous hydration, IV fluids, if you are actually planning to do something about the obstruction, if a surgery is possible or any intervention is possible, yes, you can do that. But in a terminal stage patient, continuous IV hydration for a long time in the end of life, and in the end of life especially, it is not proven to be beneficial. And although there are multiple studies in the end of life patients where they have found that IV or subcutaneous hydration does not improve the quality of life in these patients. So especially in such patients, IV and subcutaneous hydration can be avoided. NG tube, again, nasogastric tube should only be inserted when there is a large volume vomitus. So don't go on insert NG tube for all patients with bowel obstruction. If there is a significant upper abdominal distension, gastric distension, and if there is continuous intractable large volume vomiting, then there is a role of decompressing the stomach, but otherwise there is no role of putting an NG tube. NJ tube, if we can identify a partial obstruction early, and if you can put a tube, especially if that is in the stomach or something, if you can put a nasojejunal tube, it can actually serve as a way to feed the patient in the future. But otherwise, tubes and all usually not required unless there is a severe vomiting. So again, the gold standard for this kind of patients would be surgery if that is possible. Resection, bypass, stoma, all these things are usual surgical measures done for this patient. There are other measures also like palliative gastric venting and stent placement also. So whether to go for surgery or not, we'll decide based on certain factors. So these are the patients who are actually candidates for a surgery. So the patients with the single obstruction, patients with good response to anti-cancer treatment, patients with a localized disease, young patients with good performance status, and benign causes of obstruction. For example, like an adhesion or something like that. So such patients are candidates for surgery. But other patients, like a very frail patient who is not fit for surgery, a patient in an end of life with a very poor response to treatment or very high disease burden, all such patients are not candidate for surgery and they should be managed conservatively. So we'll come to the pharmacological measures for these patients. So the idea of pharmacological measures for these patients is, it is again, one important thing to keep in mind is that, so the patients who are presenting to us, especially with a malignancy with a bowel obstruction, most of them are usually not complete obstructions. They are usually partial obstructions. So that is the whole point behind designing the pharmacological measures for this treatment. So based on this, so based on the fact that most of the patients who are presenting to us with an obstruction are actually having an incomplete obstruction or a partial obstruction rather than a complete obstruction, the first step would be to try and facilitate bowel emptying or relieving the obstruction. So the measures would be steroids and prokinetics. So as I mentioned earlier, steroids will reduce the peritumor edema and inflammation, and the bowel may actually open up. And prokinetics we usually give and try to increase the peristalsis and push the bowel contents through this partial obstruction. So these are the two pharmacological measures that we can do as a first step to try to relieve the obstruction or facilitate bowel emptying. The important thing with prokinetics is that we have to give prokinetics only when we are able to review the patient. The thing is, prokinetics, if we are giving prokinetics to a complete obstruction, the increased peristalsis can theoretically result in a perforation. So when we are giving prokinetics to the patient, we always tell them that to stop prokinetics if there is an increase in the colicky pain. So that means that the prokinetics are only trying to push the bowel against a complete obstruction. So if there is colicky increase in colicky pain, we usually stop prokinetics. And again with steroids, after starting steroids, if we are not seeing an improvement within 3 to 5 days, there is no point in continuing steroids. We can stop the steroids. So we can assume that this is a complete obstruction which is not responding to steroid, and we can go to the next step. So after our first step, if our first step of facilitating bowel emptying or relieving the obstruction fails, so the next step would be to prevent the secretion so that we can prevent worsening of obstruction. So we have tried to facilitate the bowel emptying, we have failed, the obstruction is complete. So now our measures are directed on reducing the secretion that the patient will feel better. So the agents that we usually give are anticholinergics and somatostatin analogs like octreotide. Anticholinergics, the most common things that we use is buscopan or hyoscine butyl bromide or glycopyrrolate. So if that is not uh, helping, then we can go to octreotide and somatostatin analogs. So that is the next step. So associated symptoms like pain and vomiting should be treated by analgesics and antiemetics. Again, if it is proven to be a complete obstruction, we should avoid prokinetics like domperidone and metoclopramide, and we should give antiemetics like ondansetron or alloperidol or anything like that. So avoid prokinetics in a complete obstruction. So this is the basic outline of pharmacological measures for bowel obstruction. So we are coming to the final part of the presentation. So we are coming to electrolyte imbalances. So most common two things that we usually come across in palliative care is hypercalcemia and hyponatremia. So we'll go to hypercalcemia first. So most common causes of hypercalcemia are lung, breast, myeloma, and lymphoma. So partly because these things usually metastasize to brain. So and some cancers secrete some hormones which actually increase the calcium level in the blood also. So there are various mechanisms attributed to hypercalcemia and malignancy. Example are increased PTHRP, parathormone related peptide secretion, local osteolysis, excess vitamin D secretion, etc. These are the various mechanisms postulated in the development of hypercalcemia. So clinical features of hypercalcemia would be neurological features like irritability, confusion, sedation, and delirium. GI would be anorexia, nausea, vomiting, constipation, polyuria, and dehydration as a renal features. So management would be based on the severity. So according to the blood levels of calcium, so we can divide hypercalcemia as mild, moderate, and severe. So mild would be 10.5 to 11.9. So normal would be, that is the mild range. Moderate would be 12 to 13.9, and anything more than 14 milligram per deciliter is classified as severe hypercalcemia. So we usually tell to measure the albumin also when we measure calcium. That is because the actual active fraction of the calcium in the blood is the ionized calcium, which is very difficult to measure in a laboratory setup. So what most of the laboratories in our clinical practice measure is the total calcium, which is a combination of protein bound calcium and ionized calcium. So the protein bound calcium majority is bound to albumin. So it is said that, so if a patient has, for example, if a patient has a calcium of 11 and if the albumin is only 2.5 or 3, so it is said that we have to correct the calcium reading according to the albumin level so that we'll get a proper idea of how much the calcium is. So if there is a hypoalbuminemia, we have to correct calcium to the albumin levels. So this is a formula that we usually use, which is known as the Payne's formula, which is says that measured calcium plus 0.8 into 4 minus serum calcium. So we usually do it in a clinical practice. We correct the calcium level for albumin, but there are some recent papers suggesting that it is actually useless. So I'll tell the reason why. So this for all these calcium correction formulas with albumin, they assume that there is a linear relationship with the calcium level and the albumin binding. So it assumes that the ability of albumin to bind calcium is same irrespective of the levels of the calcium in the blood. So it is said that when there is a decreased calcium in the body or decrease in the albumin level, the ability of albumin to bind with the calcium increases. So it basically the idea is the calcium albumin binding is not a linear kind of thing. So there is variation in the binding capacity of albumin to calcium according to the albumin levels. So in lower albumin levels, apparently there is an increased affinity of albumin. There is an increased capacity of albumin to bind calcium. So the level of albumin binding of calcium changes with the albumin level. So there are recent studies suggesting that this corrected calcium formula is not at all accurate, but this is something that we usually do in our clinical practice. So it is uh, as of now, it is good to measure the albumin and correct calcium accordingly. Sorry, this is a typing error. I'm so sorry. 4 minus serum albumin, not serum calcium. 4 minus serum albumin. Thank you for pointing that. Sorry for the typing mistake. So treatment would be increased calciuresis by hydration, and again the diuretics are typically said to have a calciuretic effect also, but again that is clinical benefit is questionable. So for mild hypercalcemia, hydration itself is enough. So we can also give calcitonin and to reduce bone resorption, bisphosphonates and denosumab, which can actually bring down the calcium levels also. These are the various treatment options for hypercalcemia. So coming to hyponatremia. So hyponatremia in palliative care setting, or generally hyponatremia is usually divided into hypervolemic hyponatremia, hypovolemic hyponatremia, and euvolemic hyponatremia. The hypervolemic hyponatremia causes would be congestive cardiac failure and cirrhosis. Hypovolemic hyponatremia usually as a result of loss of fluid along with electrolytes from the body, secondary to vomiting and diarrhea. Euvolemic hyponatremia is basically because of syndrome of inappropriate ADH secretion. So I'm not going into the mechanism of each of these things, but these are the various classifications of hyponatremia. So the diagnosis of hyponatremia is usually made when it is less than 135 milliequivalents per liter. Symptoms usually start less than 120 milliequivalents per liter, but it can start earlier also. Life-threatening is less than 105. So symptoms like anorexia, malaise, irritability, muscle cramps, confusion, seizures, coma, etc. can be seen in hyponatremia. So depletional hyponatremia and hypervolemic hyponatremia, the management will be different. So I'm only going into the specific management of SIADH. So, I mean, again, not in detail, but just the various strategies that we use to manage syndrome of inappropriate ADH secretion. So basically like water restriction and 3% saline, and there is another drug called tolvaptan. It is a vasopressin antagonist, V2 antagonist that we can usually use. So two important things to consider in correcting correcting sodium generally is that, so in a patient with dehydration, do not give 3% saline. So whatever the sodium level is, so that is one thing to keep in mind. So always look for clinical signs of dehydration. And if a patient is dehydrated, do not give 3% saline, whatever be the sodium level. Second thing would be when you are correcting, do not correct more than 4 to 6 milliequivalents per 24 hours, which can actually lead to pontine demyelination syndrome. So the correction, do not overcorrect and do not give 3% saline in a patient who is dehydrated. Just keep these two things in mind. So again, hyponatremia correction, there is a formula available. So I have just broken down into various parts. So I'm not going into detail, but basically what we'll actually identify the total body water. Then we'll calculate the sodium deficit and multiply it by the total body water. And we'll find out the total volume of 3% saline required to correct this deficit. And then we'll calculate the time needed for correction. So that will be our rate of infusion. This is how we usually correct the hyponatremia. So these are about that is all basically like all the things that we have mentioned earlier. So another important thing is pain crisis and opioid overdose, which is actually a very important thing that we may come across. But again, I am pretty sure that this must have been covered in your previous sessions of pain and opioid things. So I'm not going into the details. So this is basically like an overview of the usual emergencies that we face in palliative care and the usual strategies that we adopt to treat these situations. So the take-home messages from this presentation would be every condition that causes patient distress is an emergency, whether it is a direct threat to life or not. So if it causes significant distress to the patient, always treat it like an emergency. The question to ask is, even if the condition is reversible, will the intervention result in a meaningful benefit? If yes, please go on by all means. But if it actually will cause more harm than good, there is no point in chasing each and everything, especially in a palliative care patient or a patient nearing the end of life. So patient advocacy is always important. Anything, if whenever possible, should be discussed with patient and the family so that the patients and families' wishes are also upheld. Thank you.
Thank you, Dr. Jewell Joseph. It's a really a big, vast topic, as you started off telling. Covering every bit of it is, but you have done an excellent job. System-wise, you've gone through and given an idea also what can be corrected and how can be identified. That is what to be importantly taken from this. Something could be done for the patient is what to be picked up early and managed appropriately. Any specific queries or questions in the chat at present? No, please feel like either someone wants to ask something, can unmute and even ask, and we can go accordingly with that. We can have a discussion for a few minutes before we go ahead with the case also. Anything anybody would like to ask? How to give subcutaneous hydration?
Yeah. How we usually do subcutaneous hydration. One thing, subcutaneous hydration, the amount of fluid that we give should be very less compared to the IV hydration that we usually give. The usual amount of fluid that we give is 500 ml, maximum up to 1 liter per day. So what we usually do is we'll put a subcutaneous needle and fix it, and then we can connect the IV line. Sorry, not the IV set as we do for an IV cannula also. The thing is, it would be slower and the amount of fluid that we give would be very less. In the sense, not more than 1 liter per day. That is the maximum that we give. So we usually do that in patients when there is difficulty in finding IV lines. That is, veins for IV. That is one thing. Second thing, for it can be used as an important measure for home care also. So what we do is, for some of our patients, we actually put a subcutaneous line, fix it, and send the patient home. The relatives or caregivers can actually give fluids through the subcutaneous line. So that is that we usually do. So basically, it's basically like giving an IV hydration, but and a much lower rate and in a much lower amount.
So the important thing is that, like, what volume, as the doctor has mentioned, the volume that you give through IV is not given through subcut. That is one thing to be understood. And that, I think you would have had a session on subcutaneous infusion. They would have had one separately or in part of their management. And the main difference is this: the volume is not the same. As he has already mentioned, 500 to 1 liter, something like that is given. And the main thing is advantage that it can be done at home. That is the important thing. Can be done at home, can be taught to the carers, and this is done in, if there are sufficient home care facilities available, this is being done. Maybe we can go for the case and then come back to the discussion point. Is there something else in the chat box? One second. How to give? That's what we have answered. Okay. Okay, Anup, can we go ahead with the case presentation and then come back? Thank you.
Ma'am, is it visible?
Yes, sir.
You can go ahead, Dr. Shibani, with the case presentation.
Good evening. Today I'm going to present case scenario on palliative care emergency. I'm Dr. Shibani. I'm senior resident from Department of Anesthesia, working in Fadamula Medical College, Mangalore. So the patient is a 65-year-old male. He has come with he's a known case of small cell carcinoma of lung. Presenting complaints are puffiness of face and neck since 1 month. There is breathlessness since 5 days, swelling of right upper limb since 2 days, hoarseness of voice since 2 days, and on lying down or bending forward, the symptoms worsens. On examination, patient is conscious oriented to time, place, and person. There is distended neck vein on the neck veins on the neck as well as on the anterior part of the chest. There is edema of face and right arm. Itching is present. Vital is temperature 98.2 degree Fahrenheit. Heart rate is 96 beats per minute. Blood pressure is 140 by 90 mmHg. There is abdominothoracic type of breathing. The saturation is 90% room air and 97% with oxygen face mask at 2 liters per minute. Respiratory system examination. On inspection, there is use of accessory muscles of respiration. There is barrel-shaped chest. There is multiple dilated veins over anterior chest wall. On palpation, there is decreased movement of right side of the chest. On auscultation, there is reduced breath sounds over the right side of the chest. Other systemic examinations are limits. So treatment, the definitive treatment is airway, breathing, and circulation. Patient should be head and elevation. Diuretics should be given with low salt diet. Glucocorticoids are given only in cases of mediastinal lymphoma. Radiation therapy is a primary treatment in non-small cell and other metastatic solid tumors. Chemotherapy is effective in small cell carcinoma and lymphoma. In case of recurrence, palliation with intravascular self-expanding stents are used. Early stenting may be necessary in patients who have severe symptoms. But this stenting itself comes with a lot of complications like pulmonary embolism, stroke, pulmonary edema. This is because of the increase in the venous return and stent migration. SCC syndrome, it is one of the most common oncological emergencies encountered in cases of metastatic cancer, non-small cell and small cell carcinoma of the lung. Diagnosis is mostly clinical and it is confirmed radiologically. It has to be promptly treated by securing airway at the earliest, and to definitely manage with chemo or radiation therapy. In cases with recurrence or severe symptoms, intravascular stents can be used as palliative measures through stenting, but the stenting comes with its own sets of complications, including reperfusion, pulmonary edema. So, discussion point. What are the indications of palliative care in this case?
We lost connection with her.
Dr. Shibani?
Mm. I think her connection has some issues.
Yes.
We'll wait for a couple of minutes and see.
Yes, ma'am.
Anu, can we just pause the recording till Dr. Shivani joins back?
So, the discussion point, what is the indication of palliative care in this case? So, the indications are to alleviate the symptoms of the patient by giving radiation therapy, uh, so that we can reduce the size of the tumor, so that the pressure symptoms are decreased, by giving steroids, oxygen to elevate the relieve the breathlessness, and by improving the quality of life, we can give supportive care like pain management, hydration, nutrition, and by providing emotional and moral support to the patient and their families to help them cope with the serious illness. Hello.
Go ahead, Dr. Shibani.
Yes, ma'am. Next, the differential diagnosis. It can be malignant pleural effusion or some thoracic aortic aneurysm or cardiac tamponade. The complications associated with the palliative care, it can be because of the radiation there can be some skin changes or esophagitis, pneumonitis. Because of the long term steroid use, patient can have osteoporosis, patient can have immunosuppression and diabetes. Because of the stent placement, as I already said, there can be pulmonary embolism, a stroke, and stent migration. And because of the central venous catheter insertion, there can be infection, thrombosis, and patient can have emotional and psychological distress like anxiety, depression, uh, existential distress. Uh, so next is what are the medical, social, or psychological implications in this case? Medical implications, there can be because of the frequent hospitalization procedures, patient can be physically and emotionally drained. And social implication is patient will not be able to go for the work and able to participate in the social activities, and even the family members, they might have to take off from the work because of his which can lead to the financial and emotional stress. And psychologically, a patient can experience anxiety, depression, and patient may it may have an impact that his loved ones are also being suffered because of his illness. And the last question is, what are the advices to be given for occupational disability? Um, the patient can work with some occupational therapist so that they can help him with the strategies to manage his physical and cognitive impairments. Patient should be made self-aware about his self-care so that he can take some break while he is working. Um, that's all, ma'am.
Thank you. We can have the discussion from all of you. What are the points, like what we have covered today and what this has brought forth to us? So I would leave it open first for all of you to either type on the chat or ask for your queries, and then and Dr. Joseph can also enlighten on us the stenting, what he wanted to add on if during the presentation which he was mentioning.
Ma'am, shall I start? Then I'll just make some points and then leave it to discussion, ma'am.
Just go ahead.
Ma'am, two things I just wanted to from the presentation regarding steroids in lymphoma. Steroids are not in the sense why steroids usually avoided in lymphoma is because if you don't have a histopathology, if you give steroids to a lymphoma, it can actually alter the pathological diagnosis. So it's not like steroids are contraindicated in lymphoma. I mean, like in SVCO due to lymphoma, we usually avoid it if we don't have a tissue diagnosis. But if we do have a tissue diagnosis and if the patient presents with severe symptoms, there is no contraindications in giving steroids. So that is the first point that I wanted to make. The second thing is the treatment options to consider. But the second thing I would just mention is uh, to know the prognosis of this patient whenever, I mean, if an SVC, superior vena cava syndrome, vena cava obstruction occurs, that alone doesn't mean that the patient treatment should be palliative. So just because a patient have a superior vena cava obstruction does not mean that the treatment has to be completely palliative. That will depend upon the stage of the disease. So in fact, it is the studies have shown that in patients with similar stages, I mean like treatable, curable stages with even with an superior vena cava syndrome, the prognosis is not different when compared to patients who do not have SVCO, SVC obstruction. So the second point I wanted to make is having an SVC obstruction alone doesn't mean that the entire treatment should be palliative. That is the second point. Third point, what will be the initial approach to the management will depend on the type of presentation. So it is usually said that only 10% of the patients are present with severe symptoms like cerebral edema and all, and only one patient of the presence or one patient of the patients present with a fatal symptom. So it's only like 11% of the total population with SVC present with the severe symptoms. So usually we'll have some time in deciding the treatment of SVC obstruction. So if it is only a minor symptom and if you can actually have a tissue diagnosis and go on with the treatment protocol like radiation or chemotherapy or whatever, we can actually go on with that. Usually it will respond, especially with tumors with good response to chemotherapy like lymphoma or non-small cell lung cancer, etc. We can actually go on with the treatment protocol as required. So we don't, if the symptoms are less severe, we don't actually necessarily address the SPC with something specific to that. We can actually go on with the treatment thing. Second thing would be in a patient with severe, I mean, life-threatening symptoms or severe symptoms. Again, the treatment decision would be like individualized. So if I mean the general, like I mean again stenting usually has a bad reputation, but again as I mentioned earlier, the recent studies and systematic reviews have shown that the technical success of endobronchial stenting is endovascular stenting is close to 95 to 97%. And clinical success, I mean the thing is after placing a stent the patient having relief is close to 93%. So it's not like stenting is inherently dangerous. It's actually like a safe thing. But again, the access to that procedure and the access to the facility is again difficult. So in such cases, other things can also be considered. So if it is actually very, if the patient presents with a life-threatening symptoms, stenting is the usual current recommendation to the initial thing to do with when a patient presents with a life-threatening symptom is stenting, endovascular stenting. That is the current recommendation. But again, RT is another option that we can consider. But the problem with RT is the sensitivity, I mean, the result of RT is only 80% when compared to the 93% clinical benefit in stenting. Second thing, as I mentioned earlier, the benefit of RT usually takes some time to manifest. In a severe patient with severe symptoms, we may not have enough time to wait for the benefit of RT to kick in. So it can take up to 2 years to see the complete benefit. Whereas with stenting, the benefits are usually immediate. So these are few things that is in favor of stenting in a patient with life-threatening symptoms. But if that is a tumor which usually responds very well to RT, RT is also an option. So that is the things that I wanted to add, ma'am.
Thank you, doctor. One thing I wanted to ask or add on was, uh, if endovascular stenting is useful, next is it commonly done? What are the facilities requirement and things, and what percentage is it done? Like from your figures and statistics, what you say, if there is 97% and response and 93% clinical response, it is very good. But is it available easily?
No, ma'am, it is not. So that is what I was trying to tell, ma'am. The thing is, stenting as such is not bad. It's not commonly done because of its side effects or low success rate. It is not commonly done because of the lack of facility. So if you have that facility, by all means, we can go for it. I mean, the thing is, the percentage of patients, especially in our setting, uh, going for endovascular stenting is really very low. That is because of the limitations of the facility, not because of the uh, low success rate or the increased side effects of stenting. That is the only point that I wanted to make. So stenting itself is not bad, but the limiting factor is the resources, not the side effects or the complications of the stenting.
Okay, just basically non-availability or the availability from various reasons and causes then.
Yes,
Non-availability.
yes, ma'am. Yes.
Okay then. Okay. And normally, generally, we say these type of patients, if you see them, you will never forget. Though, and you do get to see, because all the malignancies which were mentioned, the lung, breast, prostate, and myeloma, all four of them are so highly prevalent. For example, if you see, just randomly, I'm telling, like in the sense, randomly in the sense to give you an idea, because if you see 30, 40 patients, 20 or more than 50% of them could be from one of those four malignancies. So seeing these patients with these type of complications is there. And as Dr. Joel Joseph mentioned, even with having a high amount of obstruction, the symptom is very variable. I have seen a couple of patients, and then they do have, but it varies, and then the disease stage of the disease, everything matters. And at what stage of their presentation they are coming to the hospital, that also matters. When their symptoms are mild, sometimes they don't come in. They come in when the symptoms are more severe, and the disease progression has also happened there. So multifactorial is also to be kept in mind when you see the patient first time. So everything, every aspect of it has to be considered when you go into the management. Any other message on it? Something else is there in the chat. Is it available in government hospital? Yes, I want something similar to my query. Is it available, Dr. Joseph? Is it available what is the availability and or
Ma'am,
of this procedure?
I don't have a specific data regarding that, ma'am. but it is usually done by interventional radiology. So even in centers who have that facility, it is not widely done because the lack of resources. But again, I don't know if that is available in. I mean, that is.
Private setup. See, if it
Yeah,
is
yes,
interventional.
ma'am. I mean, in our institution, we do for patients.
Okay. Oh, very
It's
good.
done. It's done. It's there, but again, not very commonly done because of various things, ma'am. So
See,
expertise.
nowadays interventional radiology has gone to all extent, isn't it?
Yes, ma'am. Yes, ma'am.
Interventional radiology. That's why stenting has presence in so many fields.
Yes, ma'am.
Okay, so if it is done by interventional radiologist, and then it all depends on the availability of them also,
Yes.
and the facilities there.
Yes, yes.
Cost, multifactorial. Government hospital, as you once said, I'm also not aware exactly what is the availability in government setup with this. Maybe we can come out of the presentation and then see what else anybody else wants to add on or ask. Overall, other than SVC obstruction, anything else? Because if anybody wants to have any queries clarified with the other emergencies. Knowing about the possibilities and then managing them as per the goals of care, and correcting whatever can be corrected, so that once you are able to correct whatever can be corrected, gives very good benefit from quality of life perspective. So that also has to be borne in mind in when you're seeing system wise. If you see any, for example, in electrolyte imbalance and all, correcting them gives them better quality of life earlier rather than going too late. So being aware of all these possibilities will definitely come handy. Anything else anybody wants to ask? Something else. One second, let me read what's in the chat. How restlessness differ from distress syndrome? How can it be managed? Distress symptoms. How restlessness differ from distress symptoms? How can it be managed? Can you unmute and ask what you're trying to ask, please?
Yeah, I mean, little bit more clarity would be helpful.
Yes, exactly. That,
Good evening,
Dr.
ma'am.
Shaheen. Yes, go ahead.
Ma'am, want to know that restlessness and distress symptoms are both are same or different? Because at the end of life care, patient is experiencing some restlessness on their side. That is a general restlessness that is not so specific, but at that moment, how can we manage it immediately?
See, at that point of end of life care will be taken separately, but most of the time in end of life care, it is more discomfort by the family than the patient it will be. So restlessness and distress. Restlessness is a symptom. Distress is a measure what we measure. So those are the two things. And then I'll and as I said, it will be dealt separately in end of life care, managing someone at that stage of life. And I will ask Dr. Jewell Joseph also to clarify whatever he wants to tell about your query.
Hi, Dr. Shahina, right? Hi, Dr. Shahina.
Hi.
The thing is, restlessness, I understand what you are asking, because generally at the end of life, the patients will be restless. So you want to know whether it is because the patient is distressed. So I think what you are asking is how to differentiate between delirium and restlessness due to some underlying thing like pain or something. So the patient can be restless because of many things. So it can be because of an underlying like respiratory distress or pain or lot of things, and he or she can be delirious also. So one thing to look at will be his sensorium. So if you feel that the patient is restless and the sensorium is altered, it's more likely delirium than because of pain or something. So if the sensorium is all right and the patient is restless, so it may be because of an underlying symptom like pain or respiratory distress, something like that. So the thing is, it can both come together also. So it's like a clinical diagnosis for each patient. So one thing that would help you with this looking at the sensorium. So if the patient is completely not responding and unconscious, and if they are showing certain signs of restlessness, it is very difficult to identify what the exact cause is. So the exact cause is. So in such case, we'll have to make the best possible guess apparently whether what are the symptoms the patient previously had, and treat according to that. We can monitor the vitals or something like that. See if the oxygen saturation is going down or the patient is in respiratory distress. All those things that we can do. But in a conscious patient, so the thing to look at would be his sensorium to differentiate it between delirium and some underlying symptom causing restlessness.
Okay, sir. Understood. Thank you so
Thank you.
much.
Thank you.
Hope your query is answered. And as I mentioned, you will have a session on end of life care, in which also, like particularly how to manage that situation also will be dealt with. Okay. Is there, if there's no more, I don't think there's anything else. Anything else, please do ask. If not, I think I will hand over to Anup to go ahead and.
Thank you, Jewell sir, for your wonderful presentation. Thank you, Dada ma'am, for facilitating it. Thank you, everyone, for joining us. This is Anup signing off from Tipsaco Hub. Thank you. Bye.
Thank you to one and all. Take care, and we'll meet in our next session. Take care. Thank you, Dr. Jewell Joseph.
Thank you, ma'am. Thank you, everyone. Bye.
Take care, all of you.